Greetings, everyone. I'm Cabanlit.
And I am Ralph Benjo Morilla.
We are both affiliated with Mineral State University in the Department of Science and Technology, and today we're going to present our study entitled Cancer Mortality in the Philippines from 1960 to 2019, a Big Data Analysis. Well, just a quick overview, this study covers years 1960 to 2019, big data and visual analytics. Well, the public health data in the Philippines, they have been long stored in a government publication, but these data lack analysis. So we came up with a study for a visual analytics of a part of the stored raw data in our government's records, so as to help the country reach a greater platform and make the world aware, at least about the status of cancer care here in our country over decades and how it is now.
In our country, the Philippines, many deaths from non-communicable diseases are due to cancer and are considered as one of the four epidemic chronic diseases, together with cardiovascular diseases, diabetes, and chronic respiratory diseases. Cancer care and local cancer support resources were further amended, but the disease remained a silent disaster that kills approximately 300,000 Filipinos annually, 800 Filipinos per day, and 33 Filipinos per hour. A lot of initiatives were introduced to ameliorate the burden of cancer. However, no comprehensive assessment was conducted related to the trend and profile of cancer mortality over decades. Health disparities in diverse populations are influenced by interrelated factors, including sex and age, and these health gaps are crucial in alleviating current strategies for cancer beyond just the cause-specific health outcomes. Due to high cost of cancer care, Filipinos tend to resort to alternative medicine like herbal medicine and dietary supplements and even faith healers. Another problem is that the locally available initiatives are often poorly disseminated and recognized, leading to lack of awareness. To address these problems, we need to have a very comprehensive analysis that includes recent and far earlier data to assess the nation's progress in cancer care, capturing national scale changes over time. So given the differences between sexes and ages, we need to account for this. This study is the first report of age-adjusted cancer mortality, which can thus contribute to a worldwide comparison of cancer risk since rates are standardized to the world population. Also, risk particularly present in the country and some of the cancer-related efforts done by the government must be discussed or must be thoroughly discussed to understand the public's healthcare needs be better. So we use measures provided by the National Cancer Institute or the NCI. We use mortality data since it is the greatest motivation for healthcare improvements, and it is more reliably documented compared to the scope when reporting other measures instead. So for the methods, first we have acquired yearly data sets of vital health events from the PHS, or also known as the Philippine Health Statistics, online, and from each of the 1960 to 2019 sets, we have extracted the data of interest, which is the number of cancer deaths per sex, per age, and also per cancer site. Then the computation of the mortality rates, or the data computation, were followed. We computed for the specific death rates, which was used for the analysis of the trend. Next, for the profile, specifically, the proportionate mortality and age standardized rates were also computed. So we have used age standardized rates in this study so that it adheres to the global standard population from the World Health Organization, or the WHO. Next, for the analytics part, we use the Tableau software, TABLEAU, the Tableau software, to visualize the cancer mortality by cause and sex, as well as the trend line and its forecast. Meanwhile, we have used spreadsheet software for the proportion of the cancer sites and the profile per age. For the data cleaning, since this is a secondary data, data cleaning is vital. It's very important. So the Philippine Health Statistics followed the ICD-10 format, which has undergone several revisions over the years. So to handle the merging and splitting of classifications, the earlier revisions were structured to the latest ICD-10 format by using the sum function for the merge classifications and the subtraction function for the split classifications. So with this, the information reported in all of the years, in the 60 years considered in the present study, was uniform, assuring a sound basis for analysis. Also, the missing data were supplemented with the average values from the preceding and for the succeeding years. So based on the standard protocol in the data mining.
So the present analysis included sex-specific kinds of cancer. Now here for the males, we have prostate cancer. As you can see, cancer of the trachea, bronchus, and lung, or most commonly referred as lung cancer, is the leading cause among Filipino males over 6 decades, having an average rate of like 20.58. Now for the female-specific cancer sites, we have other and unspecified parts of the uterus, cervix, and uteri, and ovarian cancer, which all constitutes the higher proportion. Now breast cancer is the leading cause among Filipino females with 20.88 average rate. Other than the remainder in sex-specific kinds, the pattern of proportions is very similar in both sexes, wherein cancer of the trachea, bronchus, and lung has been the leading cause of mortality, followed by colon, rectum, and anus, leukemia, lip, oral cavity and pharynx, stomach, and liver, and intrahepatic bile ducts, respectively. Now, the values are flashed in the poster. Meanwhile, cancer of the esophagus, among others, which are not mentioned and are included in the figure, are ordered differently between sexes, but in insignificant values, and they constituted the lower proportions. So the most important explanation of the high burden of lung cancer is its association with smoking. Now, the prevalence of smoking is long established to be higher in males than in females. Now, here in the Philippines, smoking has been very alarming. As of the 2009 Global Adult Tobacco Survey, an approximately five-fold difference in smoking prevalence is present between sexes, which agrees with the disparity observed in the current findings, wherein males have higher proportion of lung cancer mortality compared to females. So there are a lot of strategies regarding tobacco control initiated in the country. However, full implementation of these policies based on the WHO Framework Convention on Tobacco Control was not observed. So for instance, the recommendation of WHO to impose 70% tax on tobacco retail price was otherwise only locally imposed at 29%, making it more accessible to consumers. In fact, among Southeast Asia and Western Pacific regions, the Philippines has the lowest rate of tobacco taxation. Now, despite that most lung cancers are attributable to smoking, 25% of like the global lung cancer cases are not. So particularly in Asia, a higher proportion of female never smokers was reported to be diagnosed with lung cancer. Now, the mechanisms by which lung cancer occurs in never smokers are very different from smokers, considering that the carcinogen that is involved is weak. So this can partly explain why lung cancer succeeds breast cancer in the leading causes of mortality from cancer among females. So breast cancer is the leading cause of cancer mortality among females. Females, they usually have higher tendencies of hormonal imbalance due to reproductive tendencies. And the typical medications prescribed include oral contraceptives. Now, there is this report from the University of the Philippines showing that females who are taking up oral contraceptives are at a higher risk for cancer localized to the breast, and also those that are undergoing like hormone replacement therapy during postmenopausal. So since breast cancer screening such as mammography, it's very costly and is only available for a specified population, the Philippines DOH, like they have this DOH breast cancer control program, it continued to resort to campaigns for monthly breast self-examination and annual physician checkups only. So imagine that. So cancer in sex-specific sites, on the other hand, it also constituted the higher proportions in both sexes. So the mortality rate of cancer in the Philippines has been, as you can see, it's been steadily increasing from 1960 to 2019, from a rate of less than 20 in the earlier years up to approaching a rate of almost 60 in the recent years. So despite the efforts like for cancer survival, it can be seen that mortality continues to rise over the years. Since risk for cancer includes alcohol abuse and smoking, conditions in the Philippines, therefore, makes its people vulnerable to unfavorable health outcomes. So both of these habits are regarded to be an alarming problem in the country, hence the high risk. So studies in Filipino communities, it revealed that like curiosity, social pressure, and parents' influence are some of the reasons that drive people into this lifestyle. So higher values can be observed among males, as what I have mentioned a while ago. However, rates in females have been considerably higher since 2010, as you can see in the graph. So for the age-specific mortality, there is this J-shaped pattern of cancer-related mortality, which can be observed across all age groups. Now, this means that there is a higher, although insignificant, rate value among infants to 4 years of age, and afterwards decline, then rise again. Now, a dramatic increase can be observed from 25 to 29 age group, as you can see in the poster, to the next, and through progressively older generations. Now, this result graphically accords to typical global patterns in age-specific mortality rates.
To conclude this study, the cancer persistently increased for 6 decades. So from 1960 to 2019, lung cancer is the leading cause of mortality among males, while the breast cancer leads among the females. The differences indeed exist, which can be attributed to complex and interrelated factors, including but not limited to sex and age, which makes the males and the elderly most vulnerable among the population.
So for the policy implications, we need to have like a multi-sectoral approach in cancer care delivery decisions. Now, the policies that influence the food system, commercial and industrial sectors, finance, among others, intending to limit the acceptability, affordability, and availability of lifestyle-related risk products. Also, there must be a further increase and regular adjustment of tax rates for unhealthy products and regulations to ensure an environment that is safe from harmful substances like our water supply, trade of meats, and etc. Now, policies that secure the allocation of sufficient funding also and fair attention to both output and non-output based research must also be accentuated, since in the Philippines, non-output based research are commonly underestimated and they're often given low budget compared to that of the output based research. So we have these references and for our acknowledgement.
Yes, we acknowledge the Department of Science and Technology, ASTHRDP, for the funding support and also for the climate change program of the Premier Research Institute of Science and Mathematics, or the PRISM, in MSU IIT. So thank you very much for listening, and that's our presentation for today.
Thank you so much.